Thank you very much for keeping it locked on SpiceFM or online, wherever you're watching us from, in the country or outside the country. We have two guests in the studio, and we'll be talking about that institution that we talked about, the U.S. President's PEPFAR.
How do you forget planning? It's 2 hours.
I remember everything.
You do?
Yeah, start again, Eric. It's, what does PEPFAR stand for?
The U.S. President's emergency plan for AIDS relief.
See?
AIDS relief.
Good.
Done.
Well
You
done.
Not
deserve
AIDS.
a prize.
AIDS.
You deserve a prize.
The F stands for?
4.
See? So the two guests who are joining us in the studio are Professor Elizabeth Bukusi, who is the Senior Principal Clinical Research Scientist at the Center for Microbiology Research at the Kenya Medical Research Institute. Okay. The other one is Professor Craig Cohen, who's a professor at the University of California, San Francisco, Department of... That one.
Just twist your tongue around.
That's one.
It's and
Gynecology and reproductive sciences. How do you say that? What?
Obstetrics.
Yeah. OBGYN.
yes,
That's
simple.
it. That's enough, right? We welcome them with the day's Proverb City.
Yes, proverbs this week have been from the country of Angola. It is no, that's not the one. Don't despise the nut. One day it will become a palm tree.
Don't despise the nut. One day it will become a palm tree. Okay. We're trying to figure out what probably this could have meant to the people of Angola at that point in time. So, Professor Cohen, what do you think they had in mind, the people of Angola?
I'm not sure about when was this quoted, or when was this written?
Many years ago.
Many
Before
years.
Angola was even known as Angola.
As Angola.
Yes.
Well, don't despise the nut, because the nut can be hard. And the nut can be something that we don't really understand what its true purpose is. But in time, if the nut gets planted and it's tended to, the nut will grow into a palm tree, which will provide more nuts and also shade. And in Angola, I imagine in the summertime, in Angola it can get quite warm. So don't despise the nut.
It can be useful. Professor Bokusi, do you say the same?
I would say 3 different things, actually.
Okay.
Given maybe sort of using 3 different examples. I think don't despise small things because they can cause a big shift. Let's think about COVID. Tiny little virus. Stopped the world. You know, if you had told us a few years ago that we would get to a point and time where nobody traveled, that flights were stopped, we wouldn't have believed you. We'd have said, there's nothing. We have
nobody
the
got out of
technology,
their
we know
house.
everything. Yeah, we said, no. And it did happen. But, you know, the other 2 things I'll mention, sort of giving an example of that is, think about HIV, which is, I guess, what we're here to talk about. Again, you can't see it with the naked eye, tiny thing, but it has made such a world of difference. In the last 40 years, HIV has been a problem. But the last thing, again, not despising the nut because it can grow into a palm tree, is small beginnings can yield very, very big things. And we're here to talk about, PEPFAR. I think there's, small beginnings, and there's been a lot that has been done. Many lives changed. Many individuals who are alive today who might not otherwise have been alive if PEPFAR hadn't happened. So
tell us about PEPFAR now that you've actually brought it up. What is PEPFAR? When was it started? Who started it? Why?
You know, that's a good question for Dr. Cohen. He's the American in the room. So he should tell us about his president's...
The U.S. president's...
Yeah.
Okay.
Emergency.
Plan for...
It's
4
relief.
is 4.
It's relief.
F is for 4.
F is for...
Yes.
So it's a great question. And it's actually a great testament to George W. Bush, who, through his insight, I think arguably, we could argue this here, has probably been the recent president who's done the most for Africa from the American perspective. So he brought PEPFAR and really saw a huge need. And I think it came from his spiritual beliefs, its religious beliefs, and his really desire to have America to support countries that were really suffering and still do suffer from the AIDS pandemic. And so he brought together some of the sharpest minds, including Tony Fauci, who obviously has become quite well known during the COVID pandemic, but is very well known and just recently retired, in fact, about a month ago. Eric Gooseby, who's actually a professor at UCSF, and a handful of other people to help design what PEPFAR could become, which essentially ended up becoming the largest bilateral donor support for health in the world, and has now led to over 50 billion US dollars, about 7 billion of that to Kenya alone, and leading to, as Professor Bukusi just mentioned, my friend Elizabeth, for almost 30 years now, to saving lots of lives, and continues to provide tremendous support to the Kenyan government and to other governments throughout the continent and in other parts of the world.
So it continues to be, so when we think about the US president, the question is, then which one? But now that you've given that, it's President George W. Bush, but then it continues to sit in the office of the President of the United States, no matter who that be?
So it's under the Department of State, although it gets administered through different departments. So Health and Human Services, the Centers for Disease Control, USAID or USAID, and the Department of Defense are the three government agencies where it actually gets administered. It also, very importantly, as you know, there's a lot of divisive politics in our country as well. But it continues to have strong bilateral support, both amongst Democrats and Republicans. So George W. Bush, Republican, followed by President Obama, Democrat, right? And even during, I shouldn't say even, but also during the Trump administration, and then now by the Biden administration, had strong support from the administration. The program has changed, been modified throughout the various administrations, but it's continued to have strong support also in Congress, which you know can be a very divisive group of individuals that it's hard for them to decide.
When it was initiated, it was to address an emergency at the point. Should this fund, this program, this plan still be called emergency plan?
That's a good question. Because we think about an emergency as something that's, urgent, needs attention, and we often think that an emergency should come to an end within a certain period of time. The challenge with HIV is that even though we keep envisioning and thinking, we can almost see that we can get to the end of it. We haven't been able to get to the end of it. When you think about any country, regardless of how large the HIV-infected individual population is, the challenge is that there's always the potential, if there isn't control, that it could really devastate a country. And so the question is always, how do we ensure those who are already infected get the treatment they need to be able to live their lives in the best way possible? How do we stop new infections? And that has been the challenge. And the issue is that we do not have a cure. For many things, if you can find a cure and can find a good way of containing it, then the emergency is over and life can go back to normal. People are now not wearing masks because even though the COVID pandemic hasn't ended, we have a better handle on it. The initial early devastation that we're seeing is not quite the same anymore. The challenge with HIV is that we are still struggling 40 years on to be able to really have a good handle and to ensure the mechanisms put in place can truly be expanded in a way that makes meaningful change. And because we still do not have a way of curing it, it remains a problem. So in that sense, the emergency isn't over.
So was it meant to address access to treatment? Was it meant to address better testing and identification? Was it meant to address how to avoid contracting HIV? What exactly was at the point of design? What was the initial focus?
I can let me give you an example that's very relevant to this discussion and relevant to our experience. So Elizabeth and I co-founded a program or a project called FACES, Family AIDS Care and Education Services, a partnership between KEMRI and University of California, San Francisco, working with the Ministry of Health. These are called implementing partners. So FACES being one of the implementing partners, and we received our support from the U.S. Centers for Disease Control. So usually you would get support. Implementing partners get support from either CDC, Department of Defense, or USAID. For us, our connection in Western Kenya is with CDC. When we started that program in 2004, treatment was available to just a few percentage of the people living with HIV. And we're talking in regions, when we're talking in what was formerly called Nyanza province, we're talking prevalences of 15 to 20%, even higher in some regions. So of adults, imagine 1 in 5, and still in some of these regions, there's still 1 in 5 people, adults living with HIV. When we started, we had started in Kisumu and also in Nairobi, a small clinic in Nairobi at Kemri. We were asked to consider working in Suba. Suba, which is now part of Homa Bay County, had the highest prevalence of HIV in the country at about a third. So imagine, amongst, how many are we here? We're 5. So essentially, 2 of us would be living with HIV. And at the time, treatment was unavailable. MSF France, or part of MSF, which of course won the Nobel Peace Prize for their amazing work they've done, had established a toehold in Sena, it's called Suba District Hospital at the time, and they were treating a handful of individuals in a county or in a sub-county or region with about 200,000 people. So again, probably about 50,000 people living with HIV and maybe a few hundred of them receiving treatment. The other individuals were dying. I mean, it's not that long ago. I'm sure we remember, right? And we're old enough in this room to remember when our friends and our relatives were dying of HIV. Yet treatment was available. Treatment was available from 1996 when it was proven that if you take 3 drugs, antiretroviral treatment, you could extend one's life potentially to have a normal longevity, right? With a high quality of life. And even the drugs now are even better and even safer than they were back in that time. So CDC asked us to consider working there. And I remember going to Suba, which is a very beautiful area on the lake. I think one of the most beautiful parts of Kenya, in fact, including the islands like Mfangano and Rusinga Island. And going there and working with the community, working with the local Ministry of Health and other stakeholders to start to develop a program. In the end, the program transitioned to another implementing partner, but by the time we left, a very high proportion of the individuals living with HIV knew their status, were on life-saving treatment, and virally suppressed. Life-changing for that community. If you go to that community now, it looks very different than it did back in 2005 or so when we first started working there.
So the immediate intervention that like the FACES program went for is awareness and sensitization on the need for testing, knowing your status. And then after that also then access to care and treatment. Would you say that that is what FACES went with, like that was their first priority?
The reason it's a priority, and you really state it well, Eric, is if you don't know your status, you can't go for treatment. You have to start by getting tested. When you get tested, then if you're negative, the question is, how do you remain negative? If you're positive, how do you then access treatment? And as my colleague Cohen has said, then you can have longevity. You can continue with your business as usual. Just reflecting back, in those days, many homesteads had grandmothers taking care of orphans because there was a subset of the population that was just dying and no longer available. And as you know, in that part of the country, there's also something that's called wife inheritance that sometimes happens. So that could devastate a whole family because one person dies, and then someone inherits the widow, but they don't know what that person died of. And then suddenly you have a whole lot of individuals who die off. You have young children who are left, older people, and a whole gap. And so there were many orphans as a result of that. So it was important that people know their status because then they can make a decision about what they're going to do. Right. So getting people on treatment was priority. Then providing opportunities for prevention was a second one. But something important that FACES did, and it was family AIDS care and education services as we called it, was we looked at a family approach if you get tested, not just you alone, can we test everybody around you? Can we test your partner, your children? Can we encourage everybody to come and get tested that people know? And if we're getting you to come into clinic, we don't want a couple, one coming in one day, coming in another, then the child has a different day for appointment if they also need to come in. Can we be efficient? They all come in together so they can support each other. One of the challenges of people getting tested and knowing their status is even disclosing it. And for many women, it was a problem because they would get tested in antenatal care. It had been provided that anyone coming into antenatal care would have the option to opt out of testing. In other words, they test you by default. Not so much, shall we test you, because then otherwise, people may not even bother to get tested, but let's test everybody unless they don't want to be tested. So they find out they're positive because of antenatal clinic, but now how do you go back? How do you say it? What if your partner doesn't want to get tested? One of the stories I remember from my visit to Suba was a young girl. She was 16 years old. She tested HIV positive. That was her third pregnancy. She was married to a fisherman. She didn't know how to disclose. He was not willing to get tested. The person who made decisions within her home was her mother-in-law. And it was very difficult. Now, when you're 16, it's your third baby, and you're HIV positive, what does the future look like for you?
Big question. As we look at that, I'm sure that there are many, many, many more examples of things like that in terms of the devastation then that was then apparent to people living with contracting. So what then did this relief in terms of a fund then present to this footprint of HIV then that was then in the country?
I mean, so these phases, again, developed over time. And the philosophy, part of the ethos, as Elizabeth mentioned, was that it was family-centered, right? So there are individuals living by themselves, but most people are connected with their family, extended families as well. And we wanted to be able to address some of the root problems as well as take care of the health needs. So I think the relief part had to do with essentially working with the local ministries of health, which gets all the way down to the health center, the dispensary, or at the larger facilities at the hospital, to help build local capacity. The ministries of health back then and today are stretched, right? The needs outstrip the actual ability to provide high quality services to the population. So FACES was able to come in, provide technical assistance, people on the ground. So FACES would hire people through the Ministry of Health, clinical officers, nurses, peer educators, community health workers, etc., and provide support for training of the leadership within, at that time, the districts, now the county, right? And that to help them to become the supervisors and the mentors of their teams, to empower them. In addition, FACES would provide the resources around for testing and also the drugs as well that are used that we've discussed. And really, I think something that sets FACES apart from many of the other implementing partners is that I think being rooted in two very strong academic institutions, Emory and University of California, San Francisco, innovation. And when I take a look at the PEPFAR programs in Kenya compared to Tanzania and Uganda, the degree of innovation that comes from Kenya is extremely high, which has led to tremendous improvements in HIV care, not just in Kenya, but throughout Africa.
There's a term that is often used when one is talking about HIV and AIDS. It's called task shifting. Because funding comes in, care and treatment has to fall under the Ministry of Health and with the health institutions that exist within the country. It's new. One doesn't quite know where to fit it, how to deal with it. And yet you have this huge population of people who need help, probably beyond the boundaries of existing health facilities. How did FACES cope with this, meeting this need that was clearly there and went outside the boundaries of the existing health systems?
Well, it goes to the task shifting that you are talking about, task shifting, task sharing. And then there was also the idea that the ministry was already implementing, which was a community-centered approach. We had the community approach that was enabling the healthcare facilities to have community members who would meet, who would be organized, who would be trying to ensure that the health facility that they were part of was being appropriately resourced and managed to be able to provide the care. But going back to the task shifting that you mentioned, there are some things that can be done by cadres of individuals who can be trained, who don't necessarily have to have a very high level of professional training. They need training, yes, but there are tasks that can be done by others. And the whole idea of task shifting and task sharing was one that allowed systems to become very efficient. Among the things people complain about when they go to a healthcare facility is, I'm going to be sitting there for very long, for very many hours. The nurse or the doctor doesn't have to do everything. There are certain things that can be done by other healthcare workers, which then frees up the other cadres of staff to be able to do the higher tasks or higher functions that require their particular attention. So that was one of the important things that needed to happen within that space. So I would say that's one of the things that we did. But I want to give another example. Sometimes when someone is in a very remote setting, it's harder to offer certain clinical services because if you're unsure, you want to ask a question and you don't know who to talk to. So one of the things that the FACES program did was come up with what we call a call line, a hotline. We called it the ULIZA, Ask. And clinicians practicing in relatively remote areas had access to other more trained individuals who would be able to answer questions if they were putting people on care, if there were complications, if there were side effects, if there are things that they were seeing among their patients that they were not sure what they were treating or what they were dealing. It's essentially using telephones as a telemedicine way or being able to remotely manage patients well when they didn't have immediate access because they didn't have more highly trained clinicians on site. That ULIZA line, from the initial work that FACE has done, went on to become a national program. NASCOP is the one that now runs it and provides it as a service available to all the clinicians all over the country. So that's the kind of innovation that Craig was talking about, that grew organically from within the program to be able to provide additional support for clinicians and improve care.
Let's take a break on that note. We'll continue right from there, from how PEPFAR and the PEPFAR programs were also supporting government programs and strategies.
This is the Situation Room, the only way to start your day.
The U.S. President's emergency plan for AIDS relief. So you've told us, professors, that, PEPFAR came in, there was a lot of money that was coming into the country, going into supporting the HIV space in the country through implementing partners, where there was technical assistance, there was human resource capacity building, there was also capacity building in terms of training for government officers, there was provision of technical assistance like giving the resources, the testing kits, the care and treatment and all. Well, at the same time, the government was also running its own programs on the side, like coming up with, policies and all on how to address HIV. We had the formation of the National AIDS Control Council, or NASCOP, that was looking at AIDS and STIs and all. These things, as they were running, money was going into the community. And a lot of it is coming from PEPFAR. Some of the money is coming also from Global Fund, other donors, coming from government itself. All right. So at what point were you linking up with the government to see what is the government plan and where do we need to fill in the gaps? And was there a plan, like, so you're coming in to fill this gap and the government knows, so here we have support coming in from PEPFAR and we shall let them do this and we tackle the other. Was there any kind of harmonized work plan?
The clinics in which we've been implementing care are government clinics, and also the faith-based or the other non-for-profit clinics. And there was even a section that has been supporting private clinics and private services. So it was not like they were in parallel. They were actually working together So the implementing partners were held accountable to really working with government partners. And the reporting lines have really been within the government systems, because among the things that were strengthening were the government reporting systems and the health information, medical information systems, to ensure that all the things that were happening, people who were under care, people who were having prevention services, that all this would be captured. So they were not really parallel, they were more working in tandem. The support, however, and as Craig mentioned earlier, even when healthcare workers came into work, they would be working at government health facility or health facilities, reporting to the government systems. The only thing was that they would have their salaries paid and supported from these mechanisms to ensure that they were working. And then the support supervision would happen from the implementing partners and the government Ministry of Health individuals on the ground. So that's really the way it's worked. But as you rightly say, part of this has been working, for example, with NASCOP, because we are following guidelines and following policies that are being implemented through NASCOP. When pre-exposure prophylaxis, we call it PrEP, HIV PrEP became available, the government and the ministry needed to first accept and ensure that drugs were registered and then provide it as a policy, provide training programs, roll it out. Now, as implementing partners, the role would be that you walk alongside government to make sure or support the functions of government, make sure people can be trained, that the guidelines are available, the training is rolled out. Once people are trained, then the services are provided. So it's really entrenched within the government services. But the question you ask, which maybe I'll throw back to Craig to answer, is about, yes, the funding has been there, but over a period of time, there has been a decline.
I just want to bring up one other point, and I'll address that. Interesting point. So, again, I mentioned innovation. Innovation is really a driver to lead to the improvement and efficiency of HIV healthcare, ultimately to benefit the people of Kenya, the people living with HIV, the people at risk of HIV. And because there have been historically these different implementing partners working in different counties and different regions, and really we're focusing on high burden counties, like in Western Kenya, for example, there are differences that have emerged. And I think some of the challenges that we had was not working with the Ministry of Health in Kisumu, but perhaps trying to get the lessons learned about how we could expand some of the approaches that FACES was taking. And I'll give you an example in a moment to then benefit people in other either neighboring or other adjacent counties. So an example is what's called PMTCT. Another tongue twister, means prevention of mother-to-child transmission. Some people have called it the prevention of parent-to-child transmission to take some of the gendered aspect out of that. Okay. So PMTCT. Right, PMTCT rates, so this is the trying to eliminate the transmission of the virus from the mother, which can happen either in utero or during pregnancy, at birth, or during the breastfeeding period, right? And we have different interventions that limit and can really eliminate to less than 1%, where without drugs and treatment, transmission occurs in about 1/3 of infants that are born to mothers living with HIV. So we pushed, Elizabeth and I pushed the FACES team, amazing team of individuals, to work with the ministry when we started our last 5-year period. So usually we get these cooperative agreements or these grants for 5-year periods. It started at the time when we started, it was about 6%. So 6% of children being born to women living with HIV were then themselves become HIV infected. Of course, they would then receive treatment. But our goal was to really eliminate HIV transmission. We pushed the team, and by the time that FACES ended, we were at about 2%. Still too high. We would like to get it below 1%, as it is in the US, and we have the ability to do so. In the country, PMTCT rates are between 8 to 9%. So what is it that FACES was doing that isn't happening in the other counties that could, with lessons learned from what was happening in Kisumu, a very high burden county, could be extrapolated to the other counties to build best practices and evaluate to, again, limit the number of children being born to HIV. And this is where one of the benefits of devolution of the government in Kenya is that essentially there are 47 governments and then the national government, right? So theoretically, there's all these different experiments going on. But I think where NASCOP comes in and NAC, which has been renamed, and don't ask me what their new name is.
National Syndemic Control Council. National Syndemic Control Council.
Okay. So those bodies have the ability, and they have to essentially develop national policies that can get picked up and adopted by the various county governments to then benefit. Because I'm sure there are other programs in other counties that are doing things better than what FACES was doing as well that we could have learned from. And there were opportunities for sharing, but I think that accountability is something that could be still built upon as we move forward with how PEPFAR is partnering with the government.
there are just so many layers here. When we talk about accountability of government, we talk about funding, which is huge when we talk about healthcare in the country. Not just with HIV, but, across the board to so many other things. Whether you want to talk about malaria, I want to talk about most current COVID. The funding issue has always, been a big one. So a couple of years ago, the PEPFAR funding that we saw was going to reduce came to light when we were looking at blood donations in the country. And that whole thing popped off and we're like, okay, so what happens here? And it was clear that, there was attention that was drawn to, look, over the next 5 years, it will reduce significantly. But then the glaring question became, will government, in terms of the responsibility for healthcare, be able to handle things, mirror the action, or improve with the capacity it has, with the available resources it has? Having worked, Prof, with FACES and seen what needed to be done to reach where we are today, looking at government responsibility and looking at dwindling funding, will the government be able to mirror or surpass what PEPFAR has been able to initiate in the country?
It's a really hard question, Odu. It can, depending on two things. One is the willingness and ability to put in funding. The second, I'll go back to what Craig said, innovation. And innovation is a lot about doing more with less, finding new ways, finding new efficiencies of being able to do things. One of the things that we have done, and as Craig said, we've worked together for close to 30 years now, and we came into the field really from an area of research. Our initial interest was around research, and it was actually sexually transmitted infection research, and HIV can be sexually transmitted. And so that's where we entered the HIV field from. But from the research angle, the question is always, what else can you do and how can you do it differently? So to me, the government can, by putting funds and increasing efficiency, but also by doing research. This is where I make a plug for KEMRI as a research institution. KEMRI is capable of doing a lot. But the amount of funding that we are getting, and even the amount of funding that has been committed by the Kenya government in general, that they should be giving to research, not necessarily just to KEMRI, but to research, we haven't met the target that we had said we would meet. If we can put more money into research, find innovation, and then as we innovate, as Craig was saying, ensure lessons learned are spread across and utilized, then yes, we would be able to do even more than has been done for us.
There's this saying that one comes across in this country, a new broom sweeps clean. That's anecdotal. I'm not certain that it can sweep cleaner than an old broom, but PEPFAR has a new global leader, Ambassador John Kengasong. He was CDC Africa's boss. Now, new to the job, new broom. If one were to look at the task ahead of him and one were to look at the needs of the countries that receive PEPFAR funding, I'll be specific, like I'll plug into now Kenya and say Kenya's needs. As people who've been practitioners and people who've been in this work of care and treatment for the longest possible time, beyond adolescence, and as PEPFAR celebrates their 20th year anniversary, again, they've moved out of adolescence as well. Way forward, what could one suggest from a practical perspective as people who've been in this field and have worked in it for a long time?
Craig, do you want to go first?
Please.
That's a really hard one. During the previous PEPFAR boss's tenure, Debbie Burks pushed a lot on using evidence-based decision-making. And she would really push the envelope on granular. Let's go down, let's look at what the issues are, and let's make decisions based on the data we actually have. And that would be the way to truly make a difference. And I think there were some important decisions made and important innovations and choices that resulted in some very good decision-making. However, the current challenge, I think, is based on the amount of funding that is available, and then based on what we have on the ground, including the COVID pandemic. That's where the challenge is. Right now, we also have a lot of non-communicable diseases that have become very prominent within a lot of low and middle-income countries.
Yeah.
And so you're not only dealing with the challenges of just HIV, there's a lot of other problems. Heart diseases, cancer. Those are big problems right now. I think every week in Kenya, you probably, if you're on enough WhatsApp groups, there's someone raising funds for somebody to go somewhere. Or you find yourself being added to a group of someone you don't even know. You know someone who knows someone who knows them. So those are the challenges. And HIV care in the last 20 years has provided a platform in which improving services for those who are living with HIV has resulted in also improving or raising standards of care for everybody else. And the question is, how do we now leverage on this? Even as we focus on issues of HIV care, how do we deal with a population that is HIV infected, that is aging and has more comorbidities, but even the rest of the Kenyan population, or the rest of the individuals, also have a lot more non-communicable diseases to deal with in this field. And how do we ensure, as the funding goes down, that the care that is provided remains good? And because of the challenge that people have consistently raised, saying, if someone is HIV positive, they end up with services which they're not paying for. But if I have anything else, and I may just have as limited resources as the next person who happens to be HIV positive, you're telling me to pay for the services. Is there equity in that? Is there justice? So I think the challenge that's going to be for the funding and the opportunities, how do you truly leverage the funding that's available to still provide quality care, make sure you're taking care of the comorbid conditions, but also ensure that the general population that has so many other concerns is also appropriately catered for with diminishing funds.
So let me continue with those thoughts, but expand a little bit. And actually, Elizabeth and I were speaking as we were waiting earlier this morning. So Kenya signed on to the UN Sustainable Development Goals. And for those of you who are unfamiliar, just very basically, it looks at health and well-being in a much broader context. So while we're focusing, and FACES has been very focused on health, obviously poverty, which is called Sustainable Development Goal 1, affects health. People who are impoverished in general have poor health outcomes. People who are food insecure and hungry, Sustainable Development Goal 2, also have poor health outcomes and been directly related to poor health outcomes, increased risk of HIV, of acquiring HIV, and also poor health outcomes among people living with HIV. FACES as a platform has looked to connect these other areas of ending poverty and ending food insecurity, which is rampant. 80% of the patients that we catered to in Kisumu County and Homa Bay and Migori counties were moderately to food insecure. Some of our listeners today don't know where their food is coming from, don't know how they're going to feed their children. Imagine, I feel bad for, and then we have these other externalities that we have very little responsibility for, although we do have individual responsibility. Climate change. As precipitation becomes more unpredictable, where Kenya may be facing a drought right now, which is going to affect food production and food security. Imagine again about how that is linked directly to the health outcomes that we're talking about around HIV, but also to the non-communicable diseases, heart disease, diabetes. Stunting in children is rampant in parts of Kenya. Reproductive health, unplanned pregnancies. So I think a vision for PEPFAR to consider is broadening the construct. while still continuing to support governments, both local at the county level in Kenya as well as national, to take on greater and greater responsibility, which will happen. It's going to happen. The people will demand it. The people need the care and treatment. But to broaden the construct to include looking at how partnerships with other ministries and other civil society partners, both on the private sector and in the NGO sector, to look at how we can improve food security in the country, how we can help to advance the economy, not just to benefit the few, but to benefit the many, and end poverty in this country. I remember I just read recently, and I was reminded, in the early 70s, South Korea's economy and Kenya's economy were on par, right? South Korea actually looked to Kenya for advice on how they can improve their economy. South Korean economy, their per capita GDP is 40 times that of Kenya now. Why did that happen? Kenyans are smart. It's not lack of intelligence, it's not lack of innovation. It's policies and other aspects that I'm sure this Situation Room is dealing with on a daily basis. And I think PEPFAR, with good governance and support and government-to-government collaboration, can help serve as a catalyst for the Kenyan government to continue to innovate, continue to develop efficient models that help to end the HIV pandemic as we know it, and end poverty and food security, and bring other benefits to society.
Can I ask, why is the PEPFAR fund reducing? And is it going to come to an end? Is it a plan? Is it a change of policy by the US government? Was this part of the program?
So it's always been part of the plan that, again, remember, it's called the emergency relief.
Oh, yeah.
So the emergencies are supposed to end. So it was always targeted to end. In fact, it should have ended a long time ago, but due again to support from frankly, the U.S. citizens, taxpayers, broad support, whether one identifies as Republican or Democrat or independent, broad support. But at the same time, acknowledging that countries need to take on and will take on greater ownership. For example, a majority of the program in South Africa, which has the largest epidemic of HIV in the world, PEPFAR support has declined precipitously as the government itself, South African government, has taken on the leading role and continues to for quite a while. So that transition is happening at different time points in different countries. Some countries like Kenya are well positioned to continue to take over these programs. Other governments in other countries are not as well prepared and will require support for a longer period of time. So it is planned that whether PEPFAR will end, it will end as we've known it, it will transition. I'm obviously not the policymaker, so I can't answer those questions. And part of it is dependent upon administration and also the government in Congress.
CT, final question.
Would you say that PEPFAR as a body, and I'm talking about the local PEPFAR representation, say in Kenya, would you say that through their partnerships that they have a clear handle on understanding what the needs are and how to innovate to meet these needs?
That's a loaded question, Siti.
Yes, it is.
You know, the easiest thing is to do what you usually say. You say yes and no. And then not say anything else beyond that. So someone can decide which part of yes and which part of no, you know. I think the needs are always changing and it's difficult to always keep a handle on them. But in general, I would say that they have made attempts to really have a good idea of what it is that's going on. And because they work very closely with NASCOP, and NASCOP does get a lot of information from the implementing partners. There are task forces that meet, different ones addressing different aspects, that there has generally been a lot of support. And I would say in general, the working relationships have been good and are going in the right direction. More can be done without a shadow of a doubt. There's always space for improvement. You know, like parents, now that kids are going back to school, people always say, you know, has done well, but can achieve higher or more
Has
effort is
potential
needed,
to.
has potential. So there's potential and more effort, they could definitely do better.
But let me just add to that. So every year, the U.S. government agencies, along with the Kenyan government, meet and create what's called the Country Operational Plan, or COP. So now we're in COP, I think, 23. I would encourage the U.S. government and Kenyan government to work together to create that as a more transparent process. We are told when we were implementing partners as phases, we were told this is the COP and this is what you will do. Well, how is that determined? Why did we not have a direct say as the people on the ground, and even more importantly, the real providers on the ground, and also the patients who are living with HIV and affected by this pandemic directly? Why isn't it a more transparent process? I think that would be a really interesting way to move forward as we want transparency in government.
That's a loaded answer. Professors, thank you very much for joining us today.
Thank you so much for having us.
And thank you for all the good work that you've done for the last, how many years again? Well, not
we
your
were on the
friendship.
ground for a good 16 years.
Well done.
Yeah.
Well done. Asante sana. Professor Elizabeth Bukusi is the Senior Principal Clinical Research Scientist, Center for Microbiology Research at KEMRI. And Professor Craig Cohen is a professor at the University of California, San Francisco, Department of Obstetrics.
Well, at least by 10 o'clock I had said something like it. So,
Gynecology and Reproductive Sciences. We'll be talking about PEPFAR and the future.